I think this has been a particularly exciting meeting over the last few days, and that to some extent was predictable. Of course, it depends on my interest. My interest is therapies. We've reached a point where some of the newer therapies are really gaining traction. And I would identify several of those, notably the GLP-1 receptor agonists, the SGLT2 blockers, and to a small extent we've had some interesting data too on the DPP-4 inhibitors. So if we take the first, in particular on Tuesday we had some data from another outcome study, a cardiovascular outcome study with a GLP-1 receptor agonist, in this case our beglutide, showing positive results for cardiovascular outcomes, myocardial infarction, stroke and CV death. Why that's important is because that drug actually isn't particularly good at lowering glucose levels or losing body weight. So this means this is a specific effect of these drugs, and it backs up data we've had from previous studies for semaglutide, for liraglutide, and even to some extent for exenatide long-acting, which tended to show the same thing. So I think we are now seeing that we can improve cardiovascular outcomes independently of lowering glucose levels or body weight. And we don't know the mechanism, but that's really exciting. And I look forward to further data there. Furthermore, one of the newer agents is also available in oral form, and we saw a presentation, not terribly exciting, but at least it proved the concept that the drug could be given orally and swallowed rather than being injected once a week as the current better agents do. Then to add to that, on Tuesday afternoon, in one of my papers presented by a colleague, he showed that you could take people on the most complex of insulin regimens, prandial insulin plus basal insulin, and replace it with the GLP-1RA. And not only replace it and get as good control, but get excellent control with less hypoglycemia, with 4 kilograms difference in weight, and with markedly lower number of injections, and of course a saving of insulin dose, in this case about 61 units a day of insulin. So not only are we getting good cardiovascular outcomes with these GLP-1RAs, we're also getting some good practical benefit which people will appreciate in clinical practice with their diabetes. Here at the meeting we've heard data on our beglutide positively. We've heard data on linagliptin, which proved safe if unexciting. Some advantage on albuminuria from the kidney, but that in my book is not terribly exciting. And we've heard some observational data on dapagliflozin and similar kind of drugs from the CVD REAL study. So we've had actually quite good exposure to clinical trials, and again it's all been on the good side. But coming up we have exciting data on the 10th of October. The DECLARE study with dapagliflozin is going to report at the American Heart Meeting, and that's the biggest study of any of the SGLT2 blockers we've seen to date, and we already had a hint of some of the results, but we need to see the full show then. Furthermore, we've had an announcement that the CREDENCE study with canagliflozin, which is a specific study looking at renal disease, has closed with positive results because the committee overseeing it said it shouldn't continue because the results were so good. We don't know the full details of the results yet because the study then has to close down and they then have to analyse and report. So we'll get that possibly around, I don't know at what meeting, Christmas. And we've got a study called REWIND, which is another GLP-1RA study, also reached closure and also due to report sometime around the end of the year. So I think it's a really exciting time. And I would emphasize the SGLT2 blockers because I mentioned the renal study. These have shown some very, very positive results in terms of protecting against progression of renal disease and type 2 diabetes. And I think they're so positive that it's really the biggest advance since laser photocoagulation therapy or statins in type 2 diabetes. And I think we're very privileged at the moment by these outcomes.